Dr. Shakeen Singh. Okay, so you can come and present your paper, Inlay Keratoplasty for Positive Vitreous Pressure.
Good afternoon. The technique is graft under host inlay PKP for positive pressure treatment in PKP managing beyond. This is a new technique. A purpose to describe a novice graft under host inlay PKP technique to prevent very serious complications related to positive vitreous pressure during PKP and achieving always successful grafting with the better visual outcome. PKP is the procedure of choice. In recent choices, it's a lamellar over full thickness procedure because of its less rejection rate and is considered to be safe as integrity of the globe is always preserved. However, PKP still stands as the most commonly performed corneal transplant technique by majority of the surgeons. Hence, prevention of the serious complication should be utmost interest of every corneal surgeon. So this is a total of 140 patients, and out of 140, 134 was with the routine, and the 6 patient was done with the graft under host technique. In those cases with the threat of a high BVP, we resorted to a new step of tissue exchange, that is the host cornea button is not removed completely as a whole, but is kept attached at 2 locations, preferably 180-degree apart, and the donor tissue is slid underneath the host cornea before complete swearing and viscoelastic injected into AC to prevent endothelial damage. 3 to 4 stage sutures are applied to fix the donor tissue to host rim and is followed by segmental host cornea cutting, and only after achieving a stabilization of the graft tissue, the host button is removed. Once the graft is secured, regular suturing with the continuous or interpreter suture is done. This is a diagrammatic picture of all those steps, 6 steps what we do. And these are small videos. For the interest of time, I will run these fast. This is when, once you feel the threat, you put the graft underneath and then you proceed with your procedure. That's going to save the sudden surge of the vitreous and making the things happen worse, like a expulsive hemorrhage. So once you have achieved this, then you can go into for completion of your sutures. A successful cornea transplant was achieved in all patients. In all 6 complicated cases, despite encountering the unsuspected PVP, there was no primary graft failure and a cornea graft remained clear. Inlay technique graft under host was no different from graft operation by the other procedure when we followed these patients, and the success rate was almost 95%. Conclusion: what was known? PKP is an open sky procedure, so there is a high risk of complications that can result in suboptimal post-operative complications. PVP during PKP is still remain challenging and unpredictable despite adequate perioperative preventive measures. It has been reported that during PKP the incidence rate of PVP is 40 to 50%. What this paper adds: this novice technique adds stepwise and segmental wise cutting of a host button followed by suturing of the donor tissue, which is placed as an inlay. Therefore, it must be incorporated in challenging cases to prevent sight-threatening complications like PVP related to vitreous prolapse or expulsive hemorrhage. Otherwise, face the expulsion of the intraocular content where you might have to abandon the procedure. Recent technique of overlay grafting can be performed, but that leads to extensive endothelial cell damage by compromising visual rehabilitation. Inlay PKP is a step forward towards achieving safe surgery, better graft survivability, and better visual recovery. Thank you.
It's nice presentation. So, like, my question is, like, don't you think that you are putting a graft under that it's causing overcrowding and more endothelial damage in that?
Sir, this is the concept in this procedure. Like, you put a graft under the host with the bed of the viscoelastic over the iris. So you have still a small space which would not be possible to do when you put the graft like an overlay. So here we are putting a graft underneath, creating some space. The endothelium is being protected by the viscoelastic at that moment. And once you are stabilized, then you can proceed on the further. Definitely you have taken all perioperative measures before you start the surgery. But in few patients you come across this kind of pictures. And in those cases, I find this is the very good procedure to save, and we can complete the procedure.
So how many cases you have done like this and before?
In this study, we did in over a year of 1 year. This is a
Okay.
140 patient, and 6 patient was like this. So there are a few more patients which has been done previously and after that.
So that's what, like, do you have, you compare your previous patients and like after patients, what are the endothelial, do you think the same amount of,
So yeah, that's what we have mentioned. It's almost the same.
almost the same?
Almost the same.
Don't you think there will be overreading at the host cornea where it is attached? Overreading
Definitely,
of the
there's a
graft.
compromise space in between. Once you are not tackle that
Because
situation,
your,
either you have to abandon the procedure because there's a high posterior vitreous pressure, or it's going to go to into expensive hemorrhage. It's a dreadful complication. So right there, when you judge that's going to be a posterior pressure, so don't complete the dissection completely. Create a space, put the graft over the viscoelastics, and then you can proceed. Stepwise you can encounter. Because of scarcity of the time, I could not explain detail the video, but once you would go through the video, you can see, okay, when there's a less space, we can proceed with this procedure.
Like, what are the things we do to prevent positive precipitation?
So usually in the perioperative period, we make the IOPs well controlled. You give glycerol, mannitol. We always give a mannitol preoperative to the patients. Always. Any patient would go to OT.
So
half an
before
hour.
you give?
Half an hour, sir.
Half an hour.
Half an hour.
Okay. So half an hour you give before and then you start doing the procedure. So it
Yeah.
will become like by the time effect. So
you
usually
see-
the 15 minutes the mannitol effect starts and it start waning after that.
So,
So 1 hour the state.
So before the OT, you give half an hour, you give a mannitol. It's going to take 5-10 minutes. And by the time you're going to start, it's going to be there.
Okay. This like how
And
many
of course,
cases you have
this
any?
is added with the Diamox too.
Yeah. No, have you had any cases of like suprachoroidal hemorrhage in your cases?
Luckily,
How
so far not.
So
I
what make you
I
feel-
opted to this procedure because one fine time I had to abandon the procedure. So we are using steel suture, and that the cornea was really much scarred. I could make it well in time. So there was a choroidal effusion. I could judge it afterwards with a B scan, but I could steel suture the immediately that time.
Okay. Another question, like when you are putting the graft under and then you are suturing, so what is the effect on corneal cylinder you get after that? Pre and like before you
So
case and
basically, what we save that time to put the graft in place. Definitely, you have an area which is less as compared to normal PKP. You have a visco with you to help it. Once you made all those 4 sutures, stay sutures appropriately, securing them in place, then you have a suture in your hand to proceed further, interrupted or continuous. I usually prefer continuous sutures, and there's no difference of astigmatic error coming afterwards.
so this is just a stay suture. You are not continuing with this. You are removing this suture after.
The 4 stay sutures that is going to make the graft stay there. Then you have your own routine suturing because it's going to contain the content there.
Okay, thank you so much.
Thank you.